So my name is Christine Torres Lockhart. So I am a general internist, but completed addiction medicine fellowship training here at Montefiore just in the last year or so. So I do a little bit of primary care in the outpatient setting and also addiction treatment. I work in one of our methadone programs. And I'm also working on launching an addiction medicine consult service that'll be available full-time at Weiler starting in mid-March. So hopefully we'll get to see a lot more of you guys soon and working with you in that capacity. For anything that I talk about or just cases that come up, I'm always happy to have you guys just email me too if anything comes up or questions, whatever. I know it's a switch day and I know it's like virtual, but I want this to be as, informal and interactive as possible. So please feel free to just jump in, shout out things, whatever. So yeah. So today we're going to talk about how to manage opioid use disorder and opioid withdrawal in the inpatient setting. I have no disclosures, but I will be bringing up a lot of abbreviations for opioid use disorder, often referred to as OUD, substance use disorders, which I will refer to as SUD, and buprenorphine, which is a common medication to use for OUD, which I will often shorthand as BUP. These are the learning objectives. But we'll sort of start with a case. So there's a 45-year-old woman with a history of opioid use disorder. She has daily intranasal heroin use. She also has hypertension. She's coming to the hospital with fever, productive cough, and shortness of breath for the last couple of days. She has a chest x-ray that shows a lower lobe pneumonia, and she's admitted for the treatment of CAP. I made this case obviously pre-COVID, so. She reports she's been using heroin for the last several years, and now she uses, quote, more than ever, despite having tried to cut back on several occasions on her own. She reports her last use of heroin is a couple of hours prior to her being admitted. On the second hospital day, she's now anxious, diaphoretic, she's having muscle cramping, and she's asking to leave the hospital before her treatment's complete. So what do you guys think is going on, or what are you worried about?
Withdrawal.
Great, yes. And what makes you think that?
She all of a sudden became very anxious, diaphoretic. Those are withdrawal symptoms, and like wanting to leave the hospital. I feel like a lot of times when you're not fully treated, it might be because they want to go and get more medication or take more drugs to feel better.
Exactly, and the timing's right too, right? So she is using a short-acting opioid, and usually you'll start to experience withdrawal symptoms anywhere between a couple hours, but usually about 12 hours after the last use. So if she's already on day 2, she certainly would be expected to be having some mild to moderate withdrawal. So how would you guys manage her?
I would think about like starting maybe like methadone 20 milligrams.
Great, methadone is a great choice. Any other meds that you guys would use?
Suboxone.
Great, yes. And so we'll talk about how to start both of those and why you would pick one over the other. And we'll do that today. And we'll talk about the new Montefiore treatment guidelines that kind of outline that. So for any of these conversations, I always sort of like to open up the presentation with a words matter slide. I think language we use in medicine is really important no matter what we're talking about, whether we're talking about disease processes with our colleagues, with each other, with our patients. But I think it's particularly important when we're talking about substance use disorders and addiction, because a lot of the terminology that we use with each other, with our patients, or specifically in the medical record, can be very stigmatizing and can actually create barriers to helping our patients access treatment. So I sort of challenge you, I do this all the time in my own practice, but when I see these sort of terms in the medical record or in discussing with others, really try to correct them to be more patient-centered. So we're centering the patient in the language we use and not centering the disease. So instead of terms like addict, user, drug abuser, really center the patient. So a patient or a person with addiction, a person or a patient with opioid use disorder. When we talk about toxicology testing, toxicology or urinalyses, they're not actually clean or dirty. Those aren't medical terms, right? They're just either positive or negative for substances. And those substances can either be expected results or unexpected results. When we talk about methadone or buprenorphine for treatment of opioid use disorder, instead of saying opioid substitution therapy, calling it just a medication for opioid use disorder, just to sort of make it analogous to some of the other chronic medical illnesses we treat. So we don't call like insulin substitution therapy, right? It's just medication for diabetes. And then also when we talk about a patient being quote unquote clean, patients aren't clean or dirty. They're just either abstinent from drug use, in remission, in recovery, things like that. So just again, challenge you to sort of recognize these in the record or in discussion and sort of make them more patient-centered when we talk about it. So obviously the opioid crisis has been in the headlines for the US. Obviously it's a problem in our city, but more specifically, when we look at the Bronx struggles with the opioid crisis more than any of the other 5 boroughs. And what we're seeing is that as the COVID pandemic has worn on, that drug overdoses nationally have been soaring. So this is some data that just is looking at overdoses nationally. And so we sort of see just even before COVID hit in 2019, we see with every subsequent month rising rates of overdose deaths. And then once COVID hit, this is just the most recent data we have, that sort of took off exponentially starting in March of 2020. And a lot of these deaths are due to synthetic opioids, so being fentanyl or fentanyl analogs, which are illicitly manufactured. And then when we look at, so that's national data, and looking a little bit more locally, what exactly is happening in terms of overdose deaths here in our borough. I just want to draw your attention to sort of the heat map on the right. Obviously the darker blue is more cases of overdose deaths. And we see obviously the South Bronx and East Harlem, so the patients that we serve, have the highest rates and numbers of overdose deaths in all of the city. Okay, and so this is data looking at 1 year from April to March. So it's capturing some of the COVID pandemic worsening as well. And then when you look over on the left, the dotted bar lines are essentially all of the overdose deaths for 2019. So you see that the Bronx has the highest absolute number of deaths for 2019. And then the actual shaded in portion are the number of deaths that have been reported for the first quarter of 2020. So that's the most recent data we have, because the medical examiner is obviously very backed up with coronavirus cases as well. So for 2019, we had the most overdose deaths. And then when we look at the data we have available for 2020, again, the Bronx is leading in absolute number and rates of overdoses. So not surprisingly, when you sort of look at the heat map of the COVID cases, it's not dissimilar. Again, the darker colors are more cases, and we see darker shades of purple in both the South Bronx and the North Bronx for the patients we serve. So our patients in particular are sort of stuck at these intersecting pandemics of the opioid overdose deaths and also the COVID pandemic as well. So all this to say that, opioid use disorder is really common in the hospital. We're seeing rising rates for hospitalizations related to opioid use. It's also really expensive to our hospital system. And as you all know, some of these hospitalizations can be incredibly frustrating for both providers and patients alike. There are a lot of misconceptions about what exactly is allowable in terms of which medications you can provide in the hospital. And so that contributes to a lot of medication underutilization. But we'll talk about how treatment is effective. It's evidence-based, particularly to initiate during acute hospital settings. And both of these things can be associated with improved patient outcomes, but also really importantly, provider satisfaction as well. So I want to talk about how to be really practical when we're talking about managing opioid use disorder and opioid withdrawal in the hospital. We don't expect that, you're going to cure someone's addiction when they're admitted to the hospital for, say, a pneumonia. So I want us to just have like really practical goals for what we're trying to achieve here. So the most important thing is that we actually treat the acute opioid withdrawal. While it's not one of the life-threatening ones that we normally think about, like alcohol or benzo withdrawal, it can be incredibly, incredibly painful and uncomfortable for patients. And so we want to sort of treat that acute withdrawal and relieve the suffering that's associated with it. In addition, like you sort of suggested, it's really important that we treat this because it can be a huge barrier to having patients complete the treatment they actually came into the hospital for. So by treating their withdrawal appropriately, we can sort of prevent any premature discharges, also known as AMAs, against medical advices, or against medical advice. And then lastly, again, really to help improve patient-provider relations, if we're appropriately managing withdrawal, it can sort of relieve some of the tension of some of these, quote unquote, difficult cases. And then lastly, this is just like a really reachable moment to sort of meet someone where they are in terms of their drug use and talk about harm reduction for if they're going to continue to use substances, how to use them more safely, and if they're interested in treatment, how to sort of capture them there and refer them to appropriate treatment. So I like this chart because it kind of goes over what the natural history of opioid use disorder is. So when someone is opioid naive, every time they sort of use a substance, they get some sort of euphoric effect, okay? And that's a sort of intoxicating high. And then with continued use, what happens is you develop tolerance. So the same amount of substance does not elicit the same sort of intoxicating effect, and you're getting diminishing effects with the same sort of amount of substance use, requiring you to use more and more. And then at some point after tolerance, you actually develop physiologic dependence. So you actually develop withdrawal when you're not using the substance. So instead of feeling a high or a euphoria, you're really just using the substance so that you don't feel withdrawal. And so you're using the substance just to feel normal. You go into withdrawal, you develop cravings, you use. And this is the sort of cycle that folks end up in. And so the goal with opioid agonist therapy, which is methadone and buprenorphine, which we'll talk about, is it's able to sort of break that cycle so that someone you can treat the sort of withdrawal symptoms, but you treat them to a level where you don't have any sort of euphoric symptoms, and they don't have to be in this sort of really negative cycle of cravings, use, withdrawal. So there are three medicines that we have for opioid use disorder. One is methadone, which is a full agonist. One is buprenorphine, which is a partial agonist, and we'll mostly talk about those. But there's also an antagonist, so it's like a total blocker at the receptor and has no activity at the opioid receptor, and that's naltrexone. But what we do know is that these medications have been well studied for many, many years and are associated with lots of really good outcomes for patients. So we know they save lives, so it improves survival. It helps people get retained in substance use treatment. It improves their quality of life. It decreases overdose. It decreases substance use. And it also decreases transmission of HIV and Hep C as well. So the one thing to know is about methadone so it's like a full agonist, right? So the more drug you give, the more activity you have at the mu opioid receptor. And so that can lead to euphoric effects, but also really analgesic effects, but also respiratory depression. So there is a risk of overdose with too much methadone and combining with other sedatives like benzos, alcohol, heroin, fentanyl, et cetera. The thing to know about buprenorphine that's very important is it's a partial agonist. So it does activate at the receptor, but it has a ceiling effect, which I often tell patients at about 50%. So with escalating doses, you do get activity at the receptor, and that's what relieves withdrawal symptoms and cravings. But once you get to about 24 milligrams or something, giving more does not get you more activity at the receptor, and it can be very protective for overdose. Okay, so no one has really overdosed from having too much buprenorphine. Okay, the other thing to know about buprenorphine is it has an incredibly high affinity for the receptor. And so if you give buprenorphine while some other full agonist is on board, it sort of kicks off that full agonist. And so it'll bring someone's activity at the receptor from like 100% to 50% really, really quickly. And that's what a precipitated withdrawal is. And is this the one thing that we want to avoid when we give buprenorphine? So the one way we make sure that we give buprenorphine at the right time is we just make sure someone is in enough withdrawal to start it, so that when you give it, you're actually activating their receptor instead of bringing them down. Does that kind of make sense? Or any questions about that principle? Okay. So this is just a summary. So methadone is the full agonist. It's dosed for OUD every day, but it does have analgesic effects for about 8 hours. And it's only able to be delivered in a methadone program or an opioid treatment program, unless someone's in the hospital, in which case you can give it while they're being managed for some other medical illness. Buprenorphine, because it's a partial agonist, it's a lot, and it has decreased overdose risk. It's a lot safer, and it can actually be provided by any outpatient provider who has a DEA-X waiver. And so that just requires 8 hours of training that you guys can do online if you have a DEA license. And same idea, it's good for 24 hours when you dose it daily for OUD, but it does have 8 hours worth of analgesic effects. So if someone's using it for pain as well, we'll often divide the dose into TID dosing. Oh, all of this to say, you can initiate buprenorphine and methadone for your patients with OUD in the inpatient setting, and you guys should feel totally empowered to do that for your patients coming in, regardless of whether or not they want to continue treatment, just so that you can relieve withdrawal and let them continue whatever brought them into the hospital so that they can complete that treatment. And then we'll just talk a little bit about the guidelines and order sets that we have for you guys to use. So this is our case again. You guys essentially talked about methadone. You said starting with maybe 20 milligrams of methadone or even starting Suboxone. So have you guys seen the opioid use disorder guidelines or used any of the order sets for starting methadone or bup in the hospital?
No.
Great. So they exist. And so there are guidelines that we made to help inpatient providers start these medicines in the hospital and help people get connected to care. So they're located on the intranet. So you can find them on the intranet under policies, guidelines, whatever. They exist. But the nicer thing is they actually also exist as just order sets embedded in Epic. So there are two. There's one is an OUD treatment initiation order set, and you can use that if you're in the ED or the inpatient wards. And it actually links directly to the guideline if you want to see it. It also includes orders for monitoring COWS, which are essentially the CWA for opioid use disorder. It includes the labs that you want to order, but the most important one being a drug screen. It includes the order for an EKG if you're worried about QTC prolongation and using methadone. And then importantly, it includes all the meds. So if you click on bup initiation, it includes all of the buprenorphine orders that you need at the dosages and the intervals that we're recommending in the guideline to start. And it also includes methadone orders at the dosages and the intervals that we're recommending in the guideline as well. And then it also includes orders for any adjuncts if someone needs like additional clonidine to help manage their withdrawal. And then also the naloxone take-home kit, which you guys should be ordering for anyone with OUD admitted to the hospital. So please feel free to use this and give me any feedback for how usable it is, what could be improved, etc. There's also a discharge order set. And so this is to use when folks are getting to be charged from the hospital. And so if someone's going to leave on Suboxone, it has the order there. And then it also includes a lot of harm reduction plans if someone's an injection drug user. And it also includes a Narcan order if they weren't able for whatever reason to get the take-home kit that you ordered. But luckily the take-home kits are available to order for both Weiler and Moses. So those should be good. But if for whatever reason you can't, you can always prescribe Narcan directly to the pharmacy. And then, like I said, other sterile supplies that are needed for injection drug users. So sterile syringes, adhesive bandages, dissolvents, alcohol swabs, things like this. So you can use this order set as well. Any questions about this? Does this seem like something you would ever use? Would this at all be helpful for your practice to make it easier to start these medications?
For sure. Yes.
Okay, great. So use them, tell other people about them, and then give me feedback if anything could be improved, because I want these to be workable for you guys. So this is the initial sheet of the opioid disorder guideline. And it essentially, I know it looks like a lot, it's essentially just like a really easy pathway to go through that helps to tell you what to do if someone is not already on treatment or what to do if they're already on treatment. So the first thing it asks is, does this patient even have opioid use disorder? And the way we diagnose that is with the DSM criteria, which we'll talk about. So opioid use disorder is diagnosed based on the DSM criteria. But just to say that this is, I want to just normalize it as like a chronic medical illness, just like anything else you guys treat, COPD, heart failure, diabetes, where it has these periods of disease flare and disease activity is higher, and then also periods of remission where the disease is well controlled. And so just to think of it as that, like any other addiction. But it's really characterized by a loss of control of substance use and using that substance despite having negative consequences, okay? So the criteria kind of fall into 3 different buckets. I think of the physical criteria or the physiologic as being tolerance or withdrawal. And then the second bucket as having this loss of control of the substance use. So cravings, not being able to cut or stop, using more substance than they intended to, or spending a lot of time trying to obtain the substance or recover from it. And then the third big bucket is, are they actually suffering negative consequences from their substance use? So are they not able to fulfill their duties as a parent or at work? Is it affecting their relationships negatively? Are they using the substance under really dangerous conditions like driving? Have they had negative consequences, like have they acquired HIV, Hep C, had an overdose, things like that? And so you can kind of go through all of these and count up how many criteria they meet, and that sort of defines how severe the disorder is. So 2 to 3 is mild, 4 to 5 is moderate, and 6 or more is severe. So say for our patient, our lady that comes in with the pneumonia, she essentially, she has tolerance, right? So she's using more than she used to just to get the same effect or to stave off withdrawal. She certainly has withdrawal because she's experiencing it in the hospital. She endorses cravings to you. She's been unable to cut down after trying. She certainly uses more than she's intended to, etc. So we haven't even gone through all the criteria with her, but just based on what we know about her, we know she meets at least 5 criteria and has moderate opioid use disorder. So sure, your patient meets criteria for opioid use disorder. And then it asks, well, are they already on treatment? So if they are on treatment, they can either be on naltrexone, and it kind of goes through a pathway of what to do if that's the case. If they're on Suboxone, it kind of goes through the pathway of what to do if that's the case. And same with methadone. If they're on methadone, what to do if that's the case. And then there's just a little bit of guidance for what to do if they sort of come in with acute pain, and how you can sort of change their dosing or their dosages based on that. But so for our patient, she's not on any treatment, right? So is she interested in ongoing treatment? And so we also created just this 1-page patient guideline that kind of goes through just some of the myths and the facts about treatment for opioid use disorder with medicines and the different medicines. So it also comes in Spanish, and you can kind of just like print that out and give it to your patient just to sort of open up the conversation with them. And so she says, sure, yeah, she's interested. And so then it says, are there any of these conditions that, you really have to consult an expert about? So pregnancy or really severe untreated psych disease. So no. And then we get to sort of the part of the workflow, which is, so which medication do you choose? Like, do you choose buprenorphine or do you choose methadone to sort of manage this patient? So the general guidance I would say is, I always sort of go, if there are any like obvious medical contraindications, like those should be considered. But all things considered, I really go with patient preference and what is most reasonable and desired by the patient, because that's the treatment that they're going to have to continue as an outpatient. And so by and large, patients prefer buprenorphine just because of the flexibility, meaning that it can be provided by a primary care doctor and prescribed to a community pharmacy and like picked up, every month like they do their other medications. And so because of that flexibility, most patients prefer buprenorphine, and I often prescribe that as first-line treatment. But say someone, had prior treatment experience with methadone, they found it really successful, they really don't like managing their own medications at home, and the structure of going to a methadone program pretty regularly and having a counselor has been very helpful for them. And if that's the case, then obviously happy to start methadone and refer them to a methadone program as well. The only real contraindications to buprenorphine are someone being on a full opioid agonist. Just because it's a partial agonist, you kind of can't have them on both generally at the same time. So if someone's in really bad pain and you're giving them like Dilaudid, oxycodone, etc., and you're not able to sort of get them off the full agonist to switch them to buprenorphine, I wouldn't use it. And then the only other limiting factor is they are just, so unstable, they can't store this medication and self-administer it, then, maybe a methadone program's better. But I have several patients who are homeless, living in shelters or street homeless, and they're able to safely manage their medication with buprenorphine. And so it is usually not a contraindication for that. And then the only real contraindications for methadone is a very prolonged QTC. So I generally think of about 500 being like the cutoff, or if they've had any history of torsades, and that would be a contraindication as well. If someone has a QTC that's like 500-ish, 450, sometimes we just start at a lower dose of the methadone and monitor closely and look at other medications they're on. And obviously being discharged to a SNF is not a contraindication to methadone, but it can be very, very challenging. So I would just talk to your social workers and discharge planners up front, because it can be a challenging discharge, and think maybe, maybe buprenorphine a little bit easier in that setting. But just to say, SNFs and rehab should never refuse a patient for being on either of these medications. All of them should be able to continue to provide these medications to those with opioid use disorder, and failure to do so is in violation of the Americans with Disabilities Act. So there have been a lot of civil rights cases and settlements with facilities for refusing this. So this is a very hot topic in the legal world right now. So if you come across these sort of discrimination cases, please forward them to me, because it's very interesting to our local Justice Department. Okay, so for Our Lady, she essentially has no contraindications to using buprenorphine. She's making payments. She likes the flexibility of, going to her primary care doctor for that. So she says, like, yeah, let's try buprenorphine. And so contraindications, she doesn't have any of those. So it's like, okay, great, let's go to the buprenorphine guide. And so again, this is just like a one-page guide that you guys can print out and kind of walks through how you start this medicine in the hospital. It has a little checklist. Make sure you ordered the urine drug screen, make sure you stopped any other full agonists they were on before you start, and you check the PDMP, etc. And all of these hyperlinks work to link you to the right places. It also includes just these contraindications, when to use with caution, things like that, for if you need reminding. But it includes the actual dosing for how you start the medicine. So the most important thing about buprenorphine that I want you to take away with is it's a very great medication, but because it's a partial agonist, you really want to make sure someone's in withdrawal before you start it, okay? And so the way we sort of grade withdrawal for opioid use disorder is called a COWS, and it's essentially like the CWA for opioid use disorder. And so you just kind of go through this sort of checklist. So it's a 10-point objective, subjective checklist that goes through different withdrawal symptoms, from pulse, are they sweating, are they restless, are they having pupil dilation, bone muscle aches, runny nose, tremors, etc. And you kind of just go through, add them up, and figure out how severe the withdrawal is. So for our patient, she's actually quite uncomfortable and has a COWS score of 19, which is like pretty profound. So that's the most important thing I want you to take away. So patients need to be in withdrawal to start this medication, okay? The general number that I want you to remember is a COWS score of 8. So as long as their COWS is 8 or greater, and you actually see like an objective sign of withdrawal, so something you can actually see and it's not just endorsed by them, you can feel very comfortable starting buprenorphine. And we start with 4 milligrams sublingually, and you really want it to dissolve under the tongue, and that can take even up to 10 minutes. So you just want the patient to be just to sort of know that up front, and know it can take a while. And then it really starts to, you'll see an effect within like 30 minutes. And so you can reassess them in an hour, recheck the COWS score, and you can continue to redose that 4 milligrams every 1 or 2 hours as needed throughout the first day for a max total dose of 16 milligrams. And then the next day, you kind of add up everything they got that first day and give it all as 1 dose in the morning. And then if they have any ongoing withdrawal symptoms later on in the day, you can give another 4 milligrams every 1 to 2 hours for that COWS score that's greater than or equal to 8. And you want to max out at a dose of 24 for day 2 or after, because the insurance will cover anyway. And so again, just wanted to make a plug for the order set, because these are the doses and the intervals that are recommended in the order set. So it makes it really easy for you guys. You don't even have to like think about it. And it also puts in the COWS order as well, which we're also doing a lot of education with the nurses so that the nurses will be able to do these nursing assessments for COWS scores and be able to dose the medication based on their COWS assessment. For now, you guys have to do the COWS assessments for induction days, so it's kind of a little bit intensive for the first day you start, but we're hoping to change the workflow so that the nurses will be able to do that for you guys. Any questions about that? Okay. So one thing I do want to talk about is what happens if you give the buprenorphine that first, and instead of them feeling better, that their COWS score actually gets a lot worse, and you're worried you have maybe precipitated a withdrawal, so maybe started it a little bit too early. So what happens in this case is that you essentially place a full action and you gave the buprenorphine, so you're kind of decreasing their activity at the receptor, and that decrease in the activity is what feels really terrible in the withdrawal that they experience. So this is most likely to happen if you start with a very low COWS score, so like 4, 5, etc. But if you're at 8 or certainly at 10 or 13, the risk of precipitating withdrawal is very low. So the higher the COWS score, the more comfortable you can feel that it's going to be initiated safely. The other high risk sort of group is someone who's on a really long acting opioid like methadone. Methadone hangs out in the system for days and days and days, sometimes weeks after someone stops using it. And so that's a case that maybe you want to consult the addiction specialist at your hospital just to help out with that transition, because it can be a little tricky. And then the other case is if someone's like a heavy fentanyl IV user, it's a very lipophilic drug, and so it hangs out in fat stores for a really long time. And so again, it just hangs out in the body for a while, so it can be a tough transition to start buprenorphine. So in those cases, I would say talk to an addiction specialist, but if you have a COWS of 8, you should feel comfortable starting. But say it happens, okay? So say you did precipitate a withdrawal. The way to manage it, which sounds a little counterintuitive, but it's actually just give more buprenorphine. So I will give 4 milligram doses every hour until someone maxes out at about 16 milligrams. Sometimes patients are just like, no, I'd rather stop. Maybe we can do this again tomorrow, in which case you can also just stop it and then just give some of the adjuncts to manage the withdrawal. So the adjuncts that are also in the order set at the right dosages and intervals are clonidine, hydroxyzine for anxiety, also Tylenol, ibuprofen for joint pains and aches, Zofran for nausea, loperamide for loose stools, etc. So those are all in the order set as well. I've only ever seen, I've done a ton of buprenorphine initiations, and I've only seen a precipitated withdrawal twice, and both cases were patients who were on methadone and started it too soon. So I think I really want you guys to feel empowered to sort of be able to start buprenorphine on your own using the guideline without an expert opinion for some of these more straightforward cases like Our Lady here in case 1. Okay, so he starts by 4 milligrams initially, and her cows goes from 19 to 13. So she gets another 4 milligrams 2 more times during the day per the algorithm for a total of 12 milligrams. And through the algorithm, she sort of gets all of that as a 12 milligram dose on day 2. And her withdrawal is well controlled for the rest of the hospital stay. And so now she's weaned to room air and she's getting ready for discharge. So the guideline also has just this 1-page discharge planner for what to do. The nice thing with buprenorphine is you just have to email this bupe@montefiore.org, and that gets connected to a nurse manager who will essentially set the patient up with a primary care visit with a provider who has an X waiver at any of these 7 primary care sites at Montefiore. And we will see them and take over their buprenorphine prescribing. You just want to make sure that they leave with enough buprenorphine to get to that visit. So if you or your attending is not X waiver, just let us know in that email and we're happy to write that prescription as well. If someone's uninsured or Medicaid pending, you can just send the prescriptions to the outpatient pharmacy and they'll do meds to bed and comp the meds for patients as well. And then for all patients who have opioid use disorder, just make sure you're discharging them with the take-home kit. And then also this has links to several harm reduction information in English and Spanish as well. So if someone's an injection drug user, to use syringe exchange programs in the city as well. Again, you should use the order set if someone's going to be discharged. You can give them the Suboxone, the Narcan, and any of the sterile supplies they need. Any questions on buprenorphine initiation?
I have a question. If we have a patient that we're discharging that we don't start on buprenorphine because they're not ready, but they might be interested in the future, can we still email that person, the bupe, or do they have to already be on buprenorphine?
Yes, please do. So email us, email Bupe at Montefiore, say, this patient's interested. We didn't start it, but please help connect them to an appointment, and we're happy to do that. The other thing you could do is if you didn't start it in the hospital, is you can still write a prescription for like a week of medicine and let them do their own home induction of buprenorphine. And so there's dot phrases we have, dot bupe home induction, and that is like actual like a 1-page document you can give the patient that gives them instructions on how to start it at home. And so, it says start when you have 5 symptoms of withdrawal, and it kind of lists them all. And so they kind of will know how to start the medication, and it tells them kind of how to dose the buprenorphine, et cetera. So even if you don't start it, certainly send us an email to connect folks and we'll see them in the clinic. But you can also be able to provide them at least, a week's worth of medicine and some instructions on how to start at home. And if you don't feel comfortable doing that, just again, email the Bupe email or me, and I'm happy to walk you through it, et cetera. Good question. Any others? Okay. So this case will be a little shorter. So a 55-year-old man, history of COPD, asthma overlap, hypertension, uses IV drugs, about 10 bags of heroin a day. He used several hours before coming into the hospital, and he's admitted with cellulitis of his left hand. He's homeless, he's in shelters, he has a lot of difficulty taking daily medicines, and he has been treated in the past in a methadone program and had good success doing that. He is interested in initiating medication for his opioid use disorder. He has no history of arrhythmias, and his EKG shows a QTC of 430. So what do you think for this guy?
Naltrexone?
Naltrexone? And why do you say naltrexone?
If he's having difficulties with daily medications, could be an option. But I mean, he's been successful with methadone, so also an option. Oh.
Yeah, no, those are both great thoughts. The nice thing about naltrexone is it comes in, the once a month injection, so that's good for adherence. The hard thing about naltrexone is it's incredibly hard to get people on it because they have to have abstained from opioids for 7 to 10 days. And so getting people through that total detox can be very challenging. But yes, I like the idea of methadone as well because he's done it before and he's found success. And so we know that agonist treatment, so methadone and buprenorphine, tend to be the most effective. But naltrexone works too, but I think it's for a special person that is really motivated to be on a medication that's not an agonist, but certainly one of the tools in our toolkit. Any other thoughts? Great. So again, just like walking down the treatment. So he's interested in treatment. And then you're kind of like, what do you do? Bupe or methadone? And so I kind of set it up as like, he really doesn't like to take his own meds daily. He's had good treatment with methadone in the past. So he doesn't have any history of torsades. His QTC is totally fine. So kind of setting him up as being a methadone person. And so someone had mentioned previously, like starting about maybe like 20 milligrams of methadone. And I think that's a great idea for this guy. So same sort of idea. This is like the 1-page initiation guide, and it has the checklist, the urine drug screen, if you're worried about a QTC, get an EKG, etc. And then also as contraindications to remind you as well. And then again, so the first thing, it's the same sort of numbers, so I want you guys to remember. So start methadone or buprenorphine when the COWS is 8 or greater. And you really do want to start with a dose of about 20 to 30 milligrams of methadone. I think that's a totally appropriate dose. So how do you pick kind of which dose to pick? Usually 20-30 is totally safe. The most you can ever give to someone who's not in a methadone program is 30 right off the bat. So you can never give more than 30 in one go for someone who's not in a program that's dose has been verified. But for folks you want to think about maybe using a lower dose, so 10 or 20, is if you really think they maybe have a lower tolerance for opioids. So say someone's just using intranasal heroin or pills, so not an IV drug user, I think about a lower dose. If they're older, I tend to think about a lower dose just because they're at higher risk for respiratory depression. And if they're on other sedating meds, have cirrhosis, have other pulmonary diseases that put them at risk of respiratory depression, like COPD or asthma, etc. And then the other important thing to know about methadone is the most you can ever give for a total dose on day 1 of an initiation is 40 milligrams. So you can give a first initial dose of 30, but you can never go more than 40 for the first day. The other thing is just if someone's being managed for acute pain, you can always think about dividing that dose to maximize the analgesic benefits as well, because those only last about 8 hours. So the COWS you want to check, make sure it's 8 or greater, and you can give 20 to 30. And then you can reassess the patient in about 4 to 6 hours. Methadone has a super long half-life, so it really takes a while to get to peak effect. So wait 4 to 6 hours. And then if they're still having ongoing withdrawal symptoms, you can give another 5 to 10 milligrams, again, for that max dose of 40 milligrams. And then same sort of idea as the buprenorphine. So you add up everything they got the day before for day 2, and you give that all as 1 dose in the morning. And then again, if they have breakthrough withdrawal symptoms, you can give 5 to 10 milligrams every 6 hours as needed. And you still want to only max out at 40. Starting on day 4 or so, you can actually max out at 50 milligrams. And you can sort of titrate up, every 5 to 10 milligrams every 3 to 5 days as needed if they're still having withdrawal. But you have to go much more slowly for methadone because it is so long acting and it takes about 4 or 5 days to reach steady state. So that's why we can't up titrate too fast. The only thing to really remember about methadone is If someone's not interested in being referred to a methadone program on discharge, you really don't want to use more than 40 milligrams a day, okay? But if they are interested in being referred to a methadone program, you can feel free to go up to 50 milligrams, 60 milligrams, as long as you're increasing the doses slowly in conjunction with this guideline, as long as they're interested in continuing care. You just don't want to put them on a very high dose of methadone and then have it be, you know, stopped abruptly when they discharge, because that would be very uncomfortable for them to go through withdrawal of that as well. Any questions about this?
So if you initiate somebody on, let's say, the max dose of 40, and they're still withdrawing, you can't increase it the following day. You have to stay at 40.
No.
Right.
Yeah, you really want to keep it at 40 for the first couple of days, until day 4, unless I think it's really bad, I would consult an addiction specialist to titrate faster than this is recommending. But if it's, say, day 2, you've already given them the max 40 and they're still having withdrawal symptoms, then I would use the adjuncts. So then you can reach for the Tylenol, the ibuprofen, the clonidine. Clonidine is your best friend for opioid withdrawal if you're not using an agonist. So clonidine is what I would reach for in addition to some of these other medicines based on whatever their symptoms are. Until you could titrate up further. But, you know, I'm a methadone doctor. I'm in my methadone clinic right now. 40 milligrams of methadone, even for someone using like several IV bags of heroin, does a really good job of quelling the withdrawal symptoms. It might not quell all of the cravings, but it does a good job of the withdrawal.
Thank you.
Good question. Anything else? Okay. So for our guy, I didn't plan you, but pick perfect dose. So I say he started at 20 milligrams a day because he does have COPD. He's a little bit older. You're a little bit worried about respiratory depression. So you start sort of on the low end. And he ends up getting titrated up to 40 milligrams by day 3, and he's feeling well. His COW score is now 3, and he's getting ready to discharge. So obviously methadone is not one of those medicines we prescribe to the pharmacy. It can only be delivered in a methadone program. So he'll need to be referred to a methadone program. So again, the nice thing about Montefiore is we have 5 different methadone programs across the Bronx. They're located at different places, but there's really no easy way to refer folks. So what I would recommend is kind of printing out this discharge guide if your social worker doesn't already know about it, and having the social worker kind of figure out which of these programs is closest to the patient, calling it, and then setting up an intake for the day after discharge so that the patient doesn't have a missed methadone dose, okay? So you just want to make sure they get their intake shortly after discharge, i.e. like essentially either same day or next day, and just acknowledge methadone programs are only doing intakes weekdays. So you can't really discharge someone on Saturday and then have them go without on Sunday and then do the intake on Monday. That would not be a good idea. And then make sure you certainly don't prescribe it. Make sure they definitely leave with a naloxone take-home kit, whether you prescribe it or do the take-home kit from the hospital. And then it's often very helpful for us to know when their last date and dose of methadone was and if they received any other controlled substances. But if it's a Montefiore OTP, we can see all the records, so that's not necessary. Any questions on this? There are these 2 emails that essentially exist for kind of like quick curbside kind of questions. So there's bupe@montefiore.org, which you also use to refer patients, but it's linked to several addiction medicine doctors that can like kind of give you a call if you have a curbside question. It says expect a reply in 24 to 48 hours, but oftentimes we check it all the time and would respond in a couple hours. And then the same sort of exists for methadone. So if you have a question about methadone or a case like a curbside, can also email that one. I'm happy to field any questions as well. Moses obviously has the addiction psychiatry service for for consults, and I will be starting an addiction medicine consult service that will be full-time at Weiler starting in March. So March 15th, we're going to start a full-time service there. And so we'll be there Monday to Friday, but we'll be available for urgent consults by phone for nights and weekends as well. And so it'll be staffed by addiction medicine docs. We'll have our addiction medicine fellows. And I believe internal medicine PGY 2s and 3s will start rotating with us there as well as part of a 2-week elective. So please think of us, please tell your attendings when you guys are at Weiler, and we'd be happy to see your patients, whether they have opioid use disorder, alcohol use disorder, whatever. Any questions? Cool. Okay, so I just have a couple of proofs we can go through really fast. So only X-waivered providers can start buprenorphine or meth in the hospital. True or false?
False.
Great. So under DEA regulations, anyone can start either of these medications in the hospital to treat withdrawal if someone's admitted for another reason. You guys don't need X waivers to do this, okay? So if anyone gives you pushback for ordering buprenorphine, again, you can refer them to the guideline, which sort of outlines all of the regulations, or let me know too, but it shouldn't be an issue. Bupe or methadone should only be started if someone wants to continue medication for long-term treatment. True or false?
Also,
Great, exactly. We can and should be using these medications to at least manage opioid withdrawal, regardless if they want to continue. And then skilled nursing facilities or long-term care facilities must be appropriately licensed to take patients on methadone or bupe for opioid use disorder.
False.
Exactly. There's nothing special about licensing they need. They just need to be able to coordinate the outpatient providers. So if you're seeing, your patients be discriminated against and rejected from facilities, let me know, because that should not be happening. So just to conclude, please manage opioid withdrawal in the hospital. It's a very reachable moment for patients and is a great way to sort of relieve their suffering and let them complete treatment of whatever brought them in. You guys have guidelines and order sets, so please give me feedback on those. And if you haven't done an X waiver training so that you could get your own X waiver, you should. You can do them all online for free at your own pace through PCSS. And any questions, always happy to answer any. And you also have all these emails for resources too. And then consult us when you're at Weiler. That's all I have. Thank you guys. And if you have any other questions, happy to stay on for a little bit longer.